Please give a warm round of applause to our third keynote speaker, Dr. Suzanne Partovi.
Hi. We're going to start off with a video that was taken while I was doing homeless medicine or street medicine, just to give you a sense of what it's like.
Hi, Raymond. How are you? Did you take your aspirin today?
One and went down.
What?
It's only one. Because I'm not interested. Like I said, control.
If you take one a week, I'm happy. Skid Row has the highest concentration of homeless in the entire country. There's a lot of sick people, there's a lot of elderly, there's a lot of people with chronic medical conditions, there's a lot of people who are suffering from substance abuse, mental illness, and so these are really the sickest of the sick that are out here. And so we're really trying to make a dent. Pretty an interesting juxtaposition. If you walk 2 blocks from our office west, you get to historic downtown LA where you have all these cute little shops and restaurants, and then 10 blocks that way is all the banks. So you have like some of the wealthiest people in America 10 blocks from Skid Row, right? So I'm Dr. Partovi. And you have an abscess on your arm?
Right.
And how long have you been using heroin for?
Well, I started at 35 and I've been using it off and on.
Okay.
I had some dry periods,
Okay.
2-3 years, stuff like that.
Okay.
We see me end up going back even after being on this.
Okay. Show me what we're dealing with.
I put this thing on here.
Okay.
The last time I had an abscess on the other arm.
Yeah.
It popped on me and I had
Okay.
it was oozing all over the place. So
Okay.
just to be on the safe side, I had
Okay.
to put this big.
Anything on your other arm?
No, that's the old one.
Okay. So here, because this specifically caters to injection drug users, it's usually skin infections or chronic wounds as a result of using needles. And they're not using them in the cleanest way possible, or what they're injecting is not super sterile. They really don't like going in the emergency room. Just anecdotally, a lot of patients say that they're treated poorly. They're kind of seen as drug addicts.
Ugh.
Sorry.
It's real sensitive.
Yeah, it is, huh? We're here to serve them to the point of whatever they want us to help them with. If it's just to give them antibiotics, even though they need, some kind of surgical thing, that's okay. And then as time goes on, they learn to trust us, that we're not judging them and that we're here for them, and that we're trying to take care of them as best as we can. We end up with lots of regulars, actually. most of the patients know me really well. So the point of street medicine is really developing relationships, and so that could be by giving someone a pair of socks first, or a Band-Aid, or treating their foot fungus. These aren't really life and death issues, but as you build relationships with them, they start to trust you. They might let you treat their blood pressure after a couple times. They might actually follow you to the clinic. Do you need more gauze? Yeah. There's a pretty high drug-using population here. Probably 2/3 of the population are using drugs in the Skid Row area, and a super high rate of mental illness. At least half are mentally ill. And I would say at least a quarter are severely mentally ill. They need to be taken care of. Sorry, that's okay. We didn't mean to scare you. Are you okay, honey? there's actually been a study that asked people that when outreach comes along, do you want us to wake you up? And they said yes.
I say that when they're awake.
Yeah. Hello. Hi. Are you okay? Talk to me. I have a chocolate and peanut butter protein bar. Okay. Oh, you put this thing.
Here you go.
There's some water. All right, honey. There you go. All right, take care. So my philosophy is if you treat someone like an animal, they will show up like an animal. If you treat them like a nice, gentle human being, they show up like a nice, gentle human being.
All right, so we'll just talk kind of briefly about the magnitude of the problem of homelessness. We'll talk about what common conditions that we see. I'll talk to you a little bit about harm reduction because that's the philosophy that we practice when we're working with the homeless. We'll talk about causes of death in the homeless. And then there's a term called vulnerability of death, so where we've actually figured out who's more vulnerable in the homeless population to die, and then solutions. So just like you heard in the video, the latest count is over 57,000 people in LA County per night. And so it ends up being about 250,000 per year. About half are chronically homeless, which means they're homeless for more than a year at a time. So that means 1 out of 250 residents of LA County is homeless. So that's kind of a staggering number. Just looking at, probably before I go on to common conditions, I was thinking you might want to know a little more statistics about maybe what causes someone to be homeless. So if you look at the statistics, I kind of said this in the video, if you look nationally, about half are severely mentally ill, and half are also physically disabled, which of course there's a lot of co-occurrence. And about a third are drug users. Of course, in Skid Row, it's a much higher number. And then the highest group of homeless, or how do I say that? Growing group of homeless are actually families. And so that probably has more to do with income and not being able to afford their housing. So some of the things that we see a lot of dermatological conditions. So that, oops, sorry. Is there a light here? Do I get a light? No? A light. No. Anyway, the picture here is actually a picture of someone with scabies, which is a type of mite that burrows under your skin, kind of similar to lice, but it goes under the skin instead of on top of the skin. We see a lot of staph infections, so that's called MRSA. And especially in the winter months, especially on the East Coast, you'll see a lot of feet issues, like trench foot. Like we don't really get that here, or maybe you guys do. And then, of course, we see a lot of respiratory issues. You're going to see more tuberculosis in this population. You're going to see more sexually transmitted infections. And actually dental issues. That's like the lowest on their priority, right, if you think about it and you're homeless. This is just an example. Again, one of the things I do is I work at the needle exchange, which was that where I was working on that abscess. So there's a lot of chronic skin issues. So this is someone who was using needles for their drug use, and they were using it continuously. This is an abscess. So an abscess is a collection of pus caused by a bacterial infection. Again, often seen in needle users. I just thought like putting up some gross pictures might be kind of fun for you guys. Other things that we see, we actually see very similar things that we would see in just the normal, for lack of a better word, the normal population. So chronic diseases such as hypertension, diabetes, COPD. COPD is like asthma or emphysema, which a lot of people have, but in the homeless, you're going to see it at like the end, stages, or, someone who had a stroke because they've had hypertension for so long that they weren't taking care of it. So again, when you're homeless, your medical care kind of is lower on the priority of of what you need for survival. So one thing I wanted to really point out, and this has been kind of my passion all along, but especially recently, is the severely mentally ill. This is a gentleman who actually lived in Santa Monica who died. He went to the hospital. He had a very, very large wound, and he said he didn't want any treatment for it. And it's a little controversial, but the laws pretty much say that people can make decisions for themselves, and so I'm part of a group of people who believe that they're at a point where they can't make decisions for themselves and they need help. So I'm of the philosophy of aggressive treatment for the severely mentally ill. So he died 4 days later after they released him from the hospital. Chronic pain is a really big issue too. One thing I've noticed is there's been a lot of trauma. So especially if you're an alcoholic or a drug user, you tend to be in a lot of accidents. And then hepatitis C is super common in the prison population from doing the homemade tattoos. So hepatitis C is an infection that you get from like dirty needles. And so a lot of drug users will have hepatitis C. So like in my clinic, when I'm dealing with the mostly heroin drug users, I'd say like 95% of them are hep C positive. And this is something that eventually can cause liver disease to where they need a new liver. So it's a pretty large issue. So I want to talk a little bit about the philosophy of harm reduction. Harm reduction started in the 80s with the onset of AIDS, where more in the Netherlands actually, they saw that using needles was a way of contracting AIDS, and so they created their own clean needles exchange organization, and that was really the beginning of it. And so if you think about it, do I want someone to continue to be using heroin? No. Is that the ultimate goal for them? In my opinion, no. But me telling them, dude, really, you should get your act together, that's not really going to do it. They know heroin's bad. It's kind of like when I went to a nutritionist and they told me, like, oh, yeah, you shouldn't be drinking Diet Pepsi. I was like, screw you, lady. Don't touch me in my Diet Pepsi. I didn't go back to her. So it really is, so that's why we talk about at the very last line where it says you meet them where they're at. I was not ready to give up my Diet Pepsi. I'm happy to say I no longer drink Diet Pepsi. But you meet them where they're at. So they come in the emergency. I was working in the emergency room once, and this guy, resident, immediately said to this guy who had an infection, so what's your plan for quitting? And he was like, yeah, I'm going to quit. That's not where he's at. Another question that would be more appropriate is like, what have you thought about in the realm of quitting? Are you there? Have you thought about it? Have you done it before? Are you thinking about it? Kind of get a sense of where they're at. And then just be okay with where they're at. Now, obviously, if they say, I'm going to go, get a gun and shoot myself, then you have to do some intervention. And so the idea is we know what the ultimate goal is, but we applaud even the minutia improvements towards that goal. So if they say they went from 2 grams a day to a half a gram a day of heroin, you're like, right on, dude, you know? So that's the whole philosophy. That's really as a really big part of my practice. Even with diabetes now, if when I'm teaching them, you know, if someone has diabetes and what kind of diet they want to eat, you know, and someone flat out says, like, well, I eat ice cream every day, and there's nothing you can do about it. I'm like, okay, do you have to have it every day? And they're like, I could do it 3 times a week. And I'm like, great. So, you know, for example, meeting them where they're at. And the most important thing is to not be judgmental, because society judges the drug users, the mentally ill, the homeless, and that's why they, like I was saying in the video, they don't want to go to the emergency room, because as soon as they see them, they're going to treat them like crap. And so if you want to be a good physician or a good clinician or a good dentist, you meet them where they're at, you treat them like they're a human being, and you don't judge them. And if you treat them like a human being, they show up like a human being. If you treat them like an animal, they act like an animal. So this is our needle exchange. And so basically you're letting the patient guide you in what they want and how you want to treat them. So I thought I'd just clean your palate a little bit with one of my puppies. So one of the things she left out in my bio is I have 5 dogs. This is one that I got on Skid Row. She lost one of her legs before I met her. Now she's my baby. Okay. So there's a really great study that I like to quote where they followed 119 homeless people in Boston. And they got data over 5 years. And my favorite part of this study is that in those 5 years, those 117 patients had over 18,000 emergency room visits alone. So imagine one ER visit is anywhere from $2,000 to $5,000 per visit. That's a lot of money for that community or that county. So people started, and this was this kind of research became really well known, and they were able to use that to say, hey, maybe it's cost effective to be housing the homeless than letting them, you know, get picked up and go to jail or go to the emergency room. So the other thing that they studied, and this is the same group out of Boston, is they started looking at the risk factors for death. So the risk factors for death were actually kind of similar to the general population. Cancer, cirrhosis, which is when your liver kind of ends up not working, heart attacks, trauma. But what they saw is if you look at that very first one, and if you look at the odds ratio, for example, someone who has HIV or AIDS who's homeless, look at the odds ratio, they're 55 times more likely to die than someone who's housed. So they were able to look at someone who's got kidney failure. They're 18 times more likely to die. So now they're figuring out of the population who's going to be more vulnerable. Was there anything out there? No. So this is what they kind of came up with, that these are kind of your causes of mortality in the homeless, and things to think about that they're increased risk of. So it's interesting to know that if they're an alcoholic and they've had frequent fractures or trauma or in cold areas, cold-related injuries, that really increases their risk of death. So those are considered more vulnerable. So based on this research, they saw that the homeless are about 3 to 4 times more likely to die than the exact same, person with the same disease that they have, but they're housed. They also saw that if they had multiple things going on, that they were even higher risk. So if you have a major medical issue, a mental illness, and substance abuse, that's like what they call the trifecta. So these are kind of people who tend to be super high risk of death. And so based on all this research, they came up with a vulnerability index. And so we can now kind of score people about how vulnerable they are for death. And what cities are doing is they go out, they find people, they try to figure out how vulnerable they are, and based on their vulnerability, they're getting them housed sooner than later. And for example, the supervisors of LA County saw that this was actually very cost effective. Like for me, I'm like more, well, it's the compassionate thing to do, but that's not what policy makers want to see, right? They want to see cost effectiveness. So they were able to prove that taking care of the homeless, one studio apartment used every day for 30 days each month for a whole year is actually going to be the best way to treat homelessness. So that's where, if you've ever heard of the housing first model, all this research kind of shows you, like, if you house them, you're going to save millions of dollars. Just in the first year of LA County doing this, they saved $70 million. So I know you might not be into where you think that saving money is important at this time in your life, and for me it's not that big of a deal, but that's how you get policymakers to make changes, is you have to show them that you're saving money. So so when we're working with the homeless, whether we're in the clinic or we're on the streets, we really want to be keeping our eyes out for who are most vulnerable. So like that woman who was lying in the middle of the sidewalk with no shoes on, and you saw I had a coat on, so for LA it was a little on the chilly side. Someone like that who has no belongings with them, that's someone who I'm going to think is more vulnerable. Or they have this huge scar going up and down, and it's like, oh, you just had an open heart surgery. They're going to be more vulnerable. Heroin addicts are super vulnerable because they have a really high risk of overdose, and overdose has been increasing over the years. And the idea is to build relationships with them. So we're not there to give them Band-Aids, even though that's how we can relate to them. We really want to build a relationship with them so that they can trust us. And if you think about it, you can do the same thing if you're in the office. It's like if someone's, kind of scared and don't want to be there, you're really just trying to build a relationship with them. I think we need to stop. Let me just see. Okay, that's it. No. Any questions? I should have said in the beginning, you're welcome to ask questions along the way. Yeah. Well, I've always been interested in what I call poverty medicine, and working with, like when I started working in Mexico. So when I was in college, I'd go down on the weekends to work at a dump site and do some medical work there. So that kind of solidified it for me, because I felt like a lot of, I got a lot out of that. And I saw how much they appreciated someone committed to them. Like I was undergrad. What could I do? But the fact that I was kind of showing up every week, they really appreciated that. And I really enjoyed feeling like I was making a difference, even if it's just, caring about people. And when I started working at the Venice Family Clinic, where Dr. Loaiza works, actually, she's your next speaker, they are committed to working with the homeless, and so that was when I started working with the homeless. It just kind of jived. Yeah. To not get scared. So remember, well, we always go with a bunch of people. But like I said, for the most part, if you're treating people nicely, they'll treat you nicely. If they're kind of out of it, or they're angry, or they're like, kind of yelling at a mirror and, being, then we just leave them alone. We're not going to, and if someone says, we don't go away, we don't want to deal with you, then we do. We honor where they're at, but we don't, we let them tell us what they need. They see us around, eventually they see that, we're not trying to screw them over, and maybe they'll get a pair of socks from us or something, and over time they'll learn to trust us. Yeah. Well, I think it's like having, the first question is you can look and see what your university offers. I know like at UCLA they have a student-run mobile clinic in Hollywood, but usually medical students will join me, or during the summer break, I'll have undergrads join me at the Skid Row clinic, the needle exchange that you saw. And as far, what was the second question? The comfortable. I think the whole being not judgmental, just going with the flow, and just being there to observe and kind of get a sense of what their life is like. As long as you're not judging them, I think you find things to connect with them. I connect with people over music or politics, or they can be very smart, and so you just find something to connect with them. Yes. I'm sorry, I can't hear you. Uh-huh. Sometimes. Yeah. It just depends on where they're at. But a lot of times, like if you're helping one person, some people will start coming up to you going, hey, what's going on, So, and just people, start get know you by seeing you out there on a regular basis. Oh, okay. Do we have to? Okay. 2 more questions and then that's it. Okay. Go ahead. Yeah, homeless family is a lot harder. I remember one of my nurses who was working in Lancaster, which is more the desert, where there's a lot of like camping out and like they're more remote. They had families, and so it's kind of similar. You have to earn their trust. I think, she was freaking out because there was a kid. And so I was like, okay, how old's the kid? And she's like, she's 3, or 3-ish. And I'm like, well, does she look, neglected? Does she look abused? And, no, she looked okay. So, we didn't feel like we had to report it. And I think that's what families are most in fear of, is like having their kids taken away. So as long as now if it's a school age kid, that's different because it's the law that they go to school. So it just depends. But there probably the resources that are available for families are work a little bit quicker because they see that that's a little bit more of a vulnerable situation. Okay.